Welcome, everyone. I'm Cynthia Snedden. I'm going to go ahead and introduce Dr. Brian Kavanagh and share a little bit about him and introduce his talk for today. Dr. Brian Kavanagh graduated summa cum laude with honors in biomedical engineering from the Tulane University School of Engineering, and then remained at Tulane to receive his MD and MPH degrees from the School of Medicine and the School of Public Health. He completed an internship at the Charity Hospital of Louisiana before entering a radiation oncology residency at Duke University, where he was an American Cancer Society Clinical Oncology Fellow. His first faculty appointment was at the Medical College of Virginia, and later he moved to the University of Colorado, where he is now professor and chair of the radiation oncology. During his career, his research interests have encompassed laboratory and translational studies of how to enhance the effectiveness of radiotherapy by modulation, tumor hypoxia, and inhibition of macrophage activation. And he is also focused on stereotactic radiosurgery, known as SRS, for brain tumors, and stereotactic body radiation therapy, known as SBRT, for extracranial tumors. Dr. Kavanagh's recent publications have addressed SRS and SBRT, as well as big data studies of selected cancer population databases. Dr. Kavanagh is involved in health policy decision-making at the national level, serving on a Medicare advisory panel. He has also served as chair of the American Society for Radiation Oncology, or ASTRO. So with that very impressive introduction, Dr. Kavanagh, we'd like to welcome you and let you know how much we appreciate you being here today.
Well, thank you so much. That was very kind of you to give me that nice introduction. And it's really a pleasure to meet with the group. So I'm going to share my screen now, if that's okay. And I'm going to lose all video apart from the screen. So you might have to tell me if it looks okay. Can you see my first slide?
Yes.
Okay, good. Well, let's just get going. So when Cynthia asked me to give this talk and try to maybe cover a variety of topics, I was a bit stuck and I had to scratch my head and think of what angle to come at. And so I went with this one, the what goes into the 2021 time capsule for the field. Now, this metaphor, this term time capsule, was actually coined in 1938 by the Westinghouse Corporation, because as a publicity stunt for the World's Fair that year, they inserted something deep into the ground, something that looked like a capsule. And inside that particular capsule, they put a lot of memorabilia that was evocative of the times, okay? And of course, a lot of writing that goes along with that. And I apologize for the offense that this particular set of text might give to anyone, but I'm just reading what the mood of the time was. Believing, as have the people of each age, that our women are the most beautiful, most intelligent, and best groomed of all the ages. We've enclosed in the time capsule specimens of modern cosmetics and one of the singular creations of our time, a woman's hat. Take that for what it's worth. They also put in some Camel cigarettes, a Life magazine, and a Cupid doll, which was popular at the time. And also, oh, by the way, some reflections from great thinkers of the time. And so Albert Einstein, as a matter of fact, contributed some words to that. And so we'll come back to what Albert might have actually said, what he actually did say in the message there. But that's the background context for what a time capsule is meant to be. So it was actually about 7 or so years ago that I was actually asked to produce, let's just say, a variation of a time capsule of radiation oncology for the JCO, the Journal of Clinical Oncology. ASCO was having a 50th anniversary, and they were going around to different cancer-related specialties and asking someone to be a guest editor and come up with 8 or 10 review papers that might be somehow important, somehow considered essential at the time, somehow considered to be landmark papers that were about to lead to great things and great progress. And so that's what we tried to do in that particular issue. And I thought what we'd do in this talk today would be to come back to that time capsule and look at what things that we predicted in 2014 are even still relevant a mere 7 years later? What, if anything, is already passé and outdated? And if we were going to do it again in 2021, what would we have to do to, what additionally would we have to put in that was not even there in 2014? But before I get to that, I'm not offended if the fact is that some of you are not so familiar with radiation oncology, maybe have never set foot in the department. And I take no offense at that. It's a smallish department. And if you haven't had a family member being treated with radiation therapy for whatever reason, or had occasion to be working with some of our research projects down here, you might not have a whole lot of awareness of that. So I am going to start off in a prologue sense, if you will, with some basics about radiation therapy, how it works, what some of the jargon is, and what some of the process of care is. And after we go through the little time capsule comparator study and comparator exercise, if you will, we'll come back to some department-specific things and just give you a little sampling of some quality and safety initiatives we have going on here, which I think are pretty good. So I just like to share with them. So, okay, without further ado, let's just get into a little bit of background. And I certainly don't know a lot about, I don't know a lot about a lot of things. I don't know much about cardiology. I don't know much about endocrinology. And so I wouldn't even know the questions to ask about that. And so I just wanted to avoid anyone feeling like they were supposed to know anything when there's no reason you should know anything. So we're going to just use a set of slides that are actually put together by ASTRO, this professional society, the American Society for Radiation Oncology, for the purpose of educating fellow health professionals about just some of the basics, like what happens to a patient when they're going to get radiation treatment, what's it all about, how's it supposed to work, and what's up with it for that matter. So, okay, the basics. Of course, it's been around for over a century. More than half of patients at some point will probably get radiation therapy as a part of their cancer treatment. And of course, radiation oncologists are the physicians who specialize in this, and we interact with other specialists in the cancer treating space to offer radiation when appropriate for either an attempted cure or to palliate some symptoms. We'll try to just touch on a few questions that might come up in people's mind if you're not familiar with radiation therapy. So what is the physical and biological basis for it? What are the clinical applications, and what's the process that a patient actually goes through when they're just walking through the process of getting radiation treatment for whatever type of cancer they might have? Okay, so the main workhorse in any radiation therapy department is something called a linear accelerator, as shown in that slide right there. It is generating photons. Photons are either called gamma rays if they come from something radioactive like a piece of cobalt, or X-rays if they are generated by machinery, which is what we usually use here. There are some other variations of radiation therapy that are given externally. Not going to talk too much about it, but there are protons, neutrons, and electrons that are also at times used. This is a little video, which I think might be more helpful than me trying to explain what it looks and feels like to have a treatment. And so I hope this plays well and shows up, and here we go. As you can see, this is a video from when we were treating somebody from Blue Man Group. We had a time, no, I'm just kidding. That's a joke. There's absolutely no video. I'm totally used to giving Zoom talks. You have no idea what the audience is or isn't saying, so you have to announce that it's a joke, and then you just put up a fake applause sign, yeah. Okay, so what you're seeing is a combination of the setup X-rays that we might be using to verify the patient's position on the treatment table, and also this little orange thing is perhaps the beam of radiation that is going towards, in this case, the tumor inside the patient's head. As the machine spins around, the opening is changing shape so that it conforms the radiation to where you want it to be. That's meant to be another little setup check X-ray. This you see is the machine spinning around as it's giving treatment. This would be a typical look for someone getting treated, in this case, like I say, for a tumor in the brain. And a couple of other bells and whistles associated with that are that you can do a low-grade CT scan to check the setup in a different way, and a couple of other little things go along with that. But that's what it sort of looks like when a patient is on the table getting actual radiation treatment. Now, I have another slide that has a little bit of a movie because people sometimes ask about a device called the Gamma Knife. We happen to have one of those on campus too. It has a very catchy product name. Whoever came up with that and was good and clever, and it resonates with a lot of people. But just to show you what that looks like and how it's a little bit different, it works a little bit differently. A patient is lying down on a table there. They have a metal frame tightly pinned to their head, and they slide into this semicircular device. On the inside of the device is a lot of machinery, some moving parts. And I apologize for that. This is, of course, taken from a product promotional video. I'm sorry you're being subjected to advertising text there. I didn't put that information there. But in any case, so what you see here, I'll stop this motion right here. So this is meant to represent a patient getting treated for, let's say, a couple different brain metastases. And so what you have from inside this machine are 192 individual little beamlets of gamma rays coming out from pieces of cobalt that are situated inside this casing. And they could be focused, as in this case, on a tumor or two in the brain. And I think you'll see that happening there. You're about to see a close-up of what might happen if the tumor is a little bit more irregularly shaped. And oh, by the way, I'm trying to figure out the anatomy that they're supposed to be. This tumor that they're about to show you is floating out somewhere in space. I have no idea. This not inside the patient's brain. This is a promotional video tumor. That's all I can say. It's not a real tumor. But anyway, if you imagine this was somewhere inside that person's brain and it's a little bit dumbbell shaped, it might be necessary to put one little hotspot focus. It's called a shot right there in that part of it. You might move along and give another little so-called shot right into the middle of it, and then another little shot right to the end of it. So those are just the two ways that some commonly used treatment platforms administer the radiation therapy. This particular device, like I said, the Gamma Knife, is actually purely for brain tumors. The one I showed you before, although it was a brain tumor example of treatment, is much more versatile and can treat tumors all around the body. Okay, so given that, what is supposed to be happening when you give radiation therapy? Well, it's supposed to be injuring the DNA, and the DNA of the tumor cells are supposed to be rendered incapable of replication, something that would be called clonogenic cell death. Of course, you're gonna have some normal tissues in the way and all around it, and they will also be exposed to radiation. The good thing is that in general, normal tissues have a little bit better capacity to repair the damage from radiation. And there's also more of them as a general rule. And so there are more stem cells and more ways that normal tissue can patch itself over if needed, if you're treating prostate cancer and glancing over the rectum or whatever. I mentioned that there are times when we're, in principle, using the treatment in a curative effort. In those situations, we're trying to kill every last bit of cancer that we think is around the body, either because it's there and has not been resected, or maybe there's some expectation of microscopic disease left after surgery. And there's also situations when we use it to try to reduce symptoms. Someone who's got a spinal cord compression from a metastatic tumor needs some relief, or someone who has a tumor pressing on an airway needs a little bit of relief right there. Unlike systemic treatments, the radiation therapy side effects all have to do with whatever part of the body you're actually working on. So as you might imagine, if you're treating a patient with radiation for breast cancer, you might get a little tenderness or skin redness, so on down the rest of the body. Head and neck cancers, you can get some temporary sore throat, and we have a variety of medications we use to get people through that. Fatigue is, of course, a generic side effect, and it happens with almost every type of treatment we give to any cancer patient in any circumstances. And it's variable for patients who are getting radiation treatments. The advances in technology over the past couple of decades, if they've done nothing else, they have at least done something good generally in terms of side effects, and with a little bit better tailoring of the delivery of dose to where it needs to be and as little as possible to normal tissues. That's been, I think, the major benefit for patients in the past several decades of technology advancement and treatment delivery techniques. So how does a patient start? Where does a patient start and where do they go along the way? So not surprisingly, they start out with seeing a radiation oncologist. It's either in a separate consultation as an outpatient perhaps, or part of one of our multidisciplinary clinics. And they're offered advice about whether radiation therapy is or isn't appropriate. And of course, we're almost always coordinating care with at least one or another member of the team, surgeon, doc, or someone. Although there are certainly a number of instances when radiation is used by itself to treat tumors, prostate cancer being a good example, and a few other ones like that, some head and neck cancers, and a few other things like that, some skin cancers. Simulation is a term you hear us throw around a lot. That's the word we use to refer to the time when the patient comes in and we begin the planning process. That particular exercise typically involves setting up the patient on a table, a flat surface like they'll be on for the treatment. We might make an immobilizing device. So in this particular example, I think you can see that the patient has a plastic mesh mask over his head. And so this particular patient would be being prepped for either brain tumor, possibly a head and neck cancer treatment, so that that part of the body stays stable during the time when they're getting treatment. After that particular exercise, we often combine the images we get there, which are just plain CT scan images, with PET scans or MRIs if we need to have a more detailed pseudo-photographic image, if you will, of where on the inside the tumor is situated. There's then this exercise of treatment planning, which is very interactive between the physician and some of the technical support staff. So the physician would be using some dedicated software to outline on cross-sectional images of the patient, the areas that need to be treated, where the tumor is situated, where there's concern for tumor. We have some trained professionals who are on the next step of the process, which is to say, are working with some dedicated software to configure the particular machine settings for that individual size and shape so that the treatment is tailored to their particular anatomy and location of tumor. And there's a lot of back and forth, very iterative process until we come up with what we think is a good plan to do the best we can to get the radiation inside the tumor and tumor-bearing areas with as little as possible elsewhere. There is another category of radiation therapy, a couple of other categories, if you will, in which instead of giving treatment externally, we might give it internally. We use this term brachytherapy for that particular mode of treatment. Brachy means short, therapy is treatment, so therapy at a short distance, if you will, as opposed to teletherapy, which is sometimes used to describe treatment coming from a machine like the Linac that I showed you before. So brachytherapy might involve putting inside the tumor or right next to the tumor one or another sort of radioactive material. And so you can see a couple of examples there. Those are some of the sort of the size of the seeds we might use for low dose rate prostate brachytherapy. There are sometimes situations where we do this in a permanent fashion, if you will. There's some situations, prostate cancer being the best singular example, in which we put radioactive little tiny pellets inside the tumor, and they will eventually decay. The radiation will eventually wear off, but it stays in there. We don't go back in and remove it. There are a lot of situations where we put in an implant temporarily, something that's holding on to the radiation. The most common example are the gynecologic cancer implants that we do. Sometimes we're giving treatments either intravaginally or in an intrauterine and intravaginal combination for cervix cancer, because there are situations where you might go with radiation as a primary treatment for cervix cancer. There's also one special one that we do more of here than most places do, and that's treatment of ocular melanoma. And so just for your amusement, I'll walk you through what that actually looks like. So the reason we do a lot of it here is because we have a good guy named Scott Oliver in ophthalmology. He's extraordinarily smart and extraordinarily skillful surgeon who's interested in ocular melanoma. And so he is the key person within a wide catchment area for referrals for people who have melanoma on the back of the eye. It's typically on the retina. Now, I'm showing you on this particular screen an image of my own eye, which was, of course, temporarily frightening. And it's because my optometrist at one point was doing one of these routine screenings, these funky, fancy autofluorescence imagings that can be seen. And she saw a little black spot, which is, to someone who knows that ocular melanomas can happen, a bit of an alarming thing. But I did actually go see Scott myself, and he confirmed that I have a hole in my head. And that is to say, I have something that I had never heard of before, but it's called a pigmented hole. And for people who have extraordinarily nearsighted eyes with a misshapen head, I guess, you can sometimes have little stretches in the retina and they wind up with little holes. But thankfully enough, I was much relieved that he told me it was not an actual melanoma. But let's show you what a melanoma actually looks like and what we might do in that particular case. And it is an example, again, of a brachytherapy therapy. Oh, no, you're not telling. So a patient probably comes to Dr. Oliver because they've already been told by their regular eye doctor that there's a spot on the back of their eye. It looks kind of concerning, and you should get that checked out by this Oliver guy. He will then do a couple of fancy images. I'm showing you the most colorful one. The most colorful one of these autofluorescence images, which sometimes have nice colors. And the one, the image on in the center, if you will, the green stuff is probably actually a little bit of a retinal detachment on the top of melanoma, because on an ordinary look, it's just going to look like usually a dark black spot. Sometimes they're unpigmented, but a dark black spot. They do ultrasounds on the eyeballs to get the size and shape, and you can see a little line here and a line there, getting the two dimensions of how big this thing is. So when that happens, he sends us then this technical information, and then our support team, including most importantly, the medical physics team, then go about the business of determining how much radiation we need to put inside of a plaque to get enough radiation dose to the surface of the tumor. That plaque I'm talking about looks like this. It looks like some kind of weird bottle cap, right, with a bunch of looped edges or a bunch of little loops on the edge of it, right? So what you're seeing is little tiny radioactive bits of iodine on the inside. They are implanted in a special type of resin. This bottle cap, if you will, is gold, and these little loops are going to be sutured in a procedure that is always incredibly cool for me to watch. In that particular OR, this is Scott right there. They have these really cool cameras that can show you what's actually going on at the time. At the moment, it's actually pointed to the side, but this is the OR itself. What you're looking at here is that he's actually placed this plaque on the side of the eyeball after having released it to be positioned around the side. And I promise you, I don't do anything important when I'm actually doing this. My role is really just a supportive role. I just find it to be a really cool thing. If the only semi-useful thing I'm supposed to do is to verify that the plaque looks like it's placed in the right position, and that's because we both look at an ultrasound image right over here to verify that the plaque itself, the gold bottle cap with iodine in it, is in the right place. It usually stays in there for about 5 days and it's taken out after that, and that's the treatment for that particular unusual type of tumor. There are also forms of radiation that are liquid, if you will, injectable radiation. So some of them are pure radioactive isotopes. So for example, radium, so FIGO, has been around for the last few years, and it is used for certain cases of prostate cancer. How that works is that radium is actually chemically a bit similar to calcium, and so it spreads around and deposits itself in bones, and then it emits a radioactive particle to the surrounding tumor cells, and so it can actually sneak in from the inside, if you will, to deposits of prostate cancer inside bones. There is another isotope that is especially exciting coming around. You'll probably hear more and more about this in the next couple of years. It's called lutetium, and it's hooked up to a PSMA ligand, prostate-specific membrane antigen ligand. So this is a little tiny bit of radioactive material hooked up to a protein that's going to latch onto prostate cancer cells, go around the body, and administer a therapeutic dose of radiation by direct deposit, if you will, being on the inside once again. And this type of concept has been around for a while and has been worked on for a while, but this might be an actual legit game-changing breakthrough. And I hate to use that word loosely, but you'll be hearing more and more about this, I'm pretty sure, in the next few years. There's a couple other variations of this so-called systemic radiation therapy, if you will. They're not really used that much. There's some that are good for lymphomas because they're some radioisotopes hooked up to antibodies that attach to lymphomas. And then, of course, there are some yttrium-90 microspheres that are used for certain liver tumors. In some places, these therapies are in the domain of radiation oncology, and in some places they are in the domain of nuclear medicine and interventional radiology. Here, it's mostly the latter. We have great relationships with people in both of those sections, and that's fine. And Memorial, our people at Memorial in the Springs happen to do more of this down there. It's just local arrangements are what they are. So, all right. So that is your general radiation therapy basics overview. So let's play the game I said we were going to play about the time capsule, that little issue where there were a number of articles meant to represent cool things that were going on in the field as of 2014, right? So this is what we'll do. What I will tell you I think is relevant or not relevant about these particular things. So we'll talk about. We had about 8 or 9 topics covered. We were instructed to get about 8 or 10 topics. We put 9 things in there, and so the question is, what's still hot? What's meh? It's kind of boring. It's like it's there, but didn't jump up and down. And is there anything that really it's gone? It's over. Ball game over. That ship has sailed. Jump the shark. Whatever. Well, in my opinion, of the 8 or 9 things we put in there, I'm gonna give about 5 of them, it's just, okay, yeah, still there, but I'm not sure we've really moved the needle with any of those things. And I'm not going to bother you with that if they're so uninteresting as to be, boring to me. I'm not sure they're going to be so interesting to you. So, however, I do think that we have at least a few that are legitimately still hot topics, no question about it. And I'll share what those are and where they fit into the game today. And I think there's one that's legitimately X'd out, and I'll describe what that is and where that came from and what that was about. Okay, so here we go. We'll start with the hot topics of the day, 2014, and that still have relevance today, 2021. Well, one of the papers we put in there addressed the mythical unicorn-like concept of value in medicine, right? Because you, I'm sure, have heard so much about this notion that there is a lot of interest and desire by a lot of people to move from fee-for-service types of arrangements when we pay for medical care to value-based arrangements. Okay, in other words, paying for value, getting a good bang for the buck, not just more stuff when you pay more for it. And so this particular piece was by some colleagues from a few different places. They happened to choose to quote from Oscar Wilde to launch into the uncertainty of what they're about to talk about. Nowadays, people know the price of everything, the value of nothing. It is generally agreed that the formula we are supposed to think about for medicine and value in medicine looks like this. It is the quality of what you're doing divided by the cost of what you're doing, right? Sounds pretty simple. Only problem is, what the heck is quality and what the heck is the cost of anything we're doing? Because those are elusive quantities and not exactly the most discrete things that are measurable. All discussions of quality of medical care begin a little over 50 years ago with this seminal paper written by a guy named Don Abedian, who's at Michigan, and he began to approach this topic of what the heck is quality of medical care. He admits right away it's difficult to define, right? And he suggests that we need a kind of a conceptual and operational definition. And he also points out, rightly, I think, that you can't just look at outcomes, because that's not totally fair, right? Because, I mean, you could say, well, you're going to look at your postoperative complications from doing an appendectomy and whatever, and have a certain outcome. And that's true to some extent. I mean, you want good outcomes, but it's also, as an isolated metric, maybe not the complete story, because you have to factor in all the other complexities that might make a person at risk for more or for a better or worse outcome. If it's a cancer outcome, it could be the extent of the tumor at the start, or if it's a side effect outcome, it could be a lot of something to do with their comorbidities. And the other thing he says specifically in this paper is almost as if he was talking directly to radiation oncologists. And I'll just say, I'll read what he says and explain how it fits. In some cases, long periods of time, perhaps decades, must elapse before relevant outcomes are manifest. In such cases, the results are not available when they're needed for appraisal, and the problems of maintaining comparability are greatly magnified. So to decode that and how it plays out for radiation oncology, I mentioned a few slides ago what are some of the typical side effects that people experience during the course of treatment? I mean, a head and neck cancer patient is going to have a sore throat during treatment. No surprise there. We're to give them gabapentin and some other medications and take care of it. That's fine. That's what they're going to experience during treatment and maybe the 30 days afterwards. There is a secondary phase of toxicities we talk about in radiation oncology, which are called late effects, which happen months to years down the road, and they're very important. So it might be the situation where, I don't know, you're treating someone for rectal cancer and treating postoperatively, and you might cause some scar tissue, which eventually leads to a small bowel obstruction because of some fibrosis down there. Or if you are talking about someone with lymphoma in the mediastinum, child with lymphoma perhaps you're treating, you might want to worry about what is a delayed late cardiac effect and get rid of the lymphoma, the lymph nodes in the chest, but you're also giving some radiation to the heart nearby, just a little bit unavoidably scatters over. And so we are especially beholden to think about late effects or delayed side effects whenever using radiation therapy. So the way that the authors I mentioned in their particular review article from 2014 went on to develop this whole complexity about how you even approach figuring out what value is in anything, especially radiation oncology. The first acknowledgement is that the costs of services are really hard to know. I mean, doctors don't know what the heck things cost, and charges for the same procedure, vary very widely. I think some of you may be paying attention to some of the legislation that's actually going on in the Colorado state legislature right now. There's a proposal for some new ways to revise insurance coverage in this state so that there would be a whole heck of a lot more transparency so that these variations in charges would be exposed, and maybe that would inform consumers, and maybe that would change behavior, and maybe that would lower costs. And so that's an important point. It's a widely recognized challenge, and it's not so easy to fix. Also, in the abstract sense, patients don't behave like perfect economists, right? I mean, you're at the mercy of what you hear from your physicians or anybody else or the internet about what you're supposed to do. The way most insurance plans are structured with, a deductible, if you reach your annual deductible and it's December and you're sort of thinking, well, maybe I should get another scan just for good measure. Decisions are sometimes made inefficiently for reasons that are, just a function of the way that the structure, everything's structured. All right, be that as it may, these folks put together this notion of saying, well, if you want to really combine the classic Donabedian methodology or construct of quality of medical care, it has a structure, it has a process, it has outcomes that are at least a little bit relevant. You divide that by the cost, which, to get to, you have to be transparent. Okay, fine. Well, that's all well and good. So sure, to some extent, that was a thought exercise, but a good discussion, because forget the hypothetical, because we are actually about to have a value-based system thrust upon us in radiation oncology. There has been one other experiment in oncology prior to this, but there will be, beginning in 2022, something called the radiation oncology model, which is coming out of CMS, which is the Center for Medicare and Medicaid Services, and CMI should be MMI, the Center for Medicare and Medicaid Innovation. There should be an extra M in there. This is going to be an experiment in paying for cancer treatment services with radiation a different way. Instead of paying fee for service, you're going to have an episode-based bundled payment. The rates that are going to be paid to individual practitioners will be a blend of national averages and the local historical rates. There will be 16 diagnoses included. You see them listed there. Most of the common diagnoses we treat, excuse me. After some delays related to the pandemic, no surprise, it's going to be starting up next January. The idea is that about 40% or so of all Medicare episodes will be within this model. And to determine who's going to be in or out, there was a random allocation by zip code. And there are a whole lot of other devilish details on the inside. There's some annual adjustments that are made, and I could talk for an hour and a half, put everybody to sleep, and still not get through the muck of this particular model. But be that as it may, it's coming. And the reason we are particularly paying attention to it is that if you look at the national landscape, the zip codes which were picked here, there, and everywhere else, oh, guess what? Our friends in Colorado Springs, our division down there, are going to be in the model. So we are very much in tune to it. It's not going to be happening in Metro Denver. It's not going to be happening in the northern aspect of the system. However, we are very much in preparation now to how to begin to wrap our heads around the challenges that are associated with night and day differences in how we bill services for patients who are being treated under this alternative payment model, and all of the other things that are going to go along with that. So we hope for the best with that, and I think we give pretty efficiently delivered service, and I think we're going to be okay with this, but it's going to be something, and we're all going to just have to take a deep breath and get ready for it. Okay, well that's one thing that was mentioned in 2014. It was a hot topic, and it's gotten super hot, supernova hot now. All right, what's another hot topic? Well, okay, we have our own colleagues. So when you put together one of these, invited piece issues, everybody knows that the guest editor is gonna invite a couple of their friends, right? A couple of the people at their own place, but you can't overdo that, right? Well, it so happens we have Christine Fisher and Rachel Rabinovich, who are actually legitimately nationally recognized experts in breast cancer anyway. So there was no qualm about it that, asking those two to write a really nice review paper about what's happening for radiotherapy for breast cancer was a good idea. And I would say that everything they included in their particular piece remains hot, relevant, absolutely up to speed and in the moment. What you see there is a table summarizing what I would say is the major trend toward modification of how we do radiation therapy for breast cancer that's happened in the past several decades. And so the line on top, if you will, is representative of a sequence of treatments that might have been done traditionally for decades in a standard sort of way, 5 to 6 weeks of daily treatments given as an outpatient once a day, really good results following lumpectomy to prevent the gas from coming back. But in the ensuing, I should say, most recent couple of decades, there have been efforts to use improvements in technology and a couple of new ways of thinking about it to get more and more convenient with how we administer the treatment, convenient for patients and less resource intensive for the system, if you will. I admit that most of them were driven by some European groups who, of course, have different structures to their healthcare systems, and so they are incentivized to be more efficient about their treatments. But be that as it may, those regimens of treatment have come to our shores and have been in place for a while. So nowadays, it is unusual to have a patient need to go through a full 6 or so weeks of treatment. And in most cases, you can treat them in half that time. And as a matter of fact, the most recent evidence coming out in some really nicely done, well-structured randomized studies is that for some patients, you can even get it done in 5 individual treatments. Very efficient, very nice for the patient, easier on the patient, easier all the way around. Financial implications, yes, but putting those aside, a better thing, an improvement in the quality of care for patients by a careful advancing of the field in that direction. And it continues to go in that direction. Okay, so that's hot stuff then, that's hot stuff now, all good. All right, what's another thing that was hot stuff then, hot stuff now? Well, here's a piece written by colleagues at some other institutions, which is called Radical Irradiation of Extracranial Oligometastases. And so I'm going to explain to you what they are actually talking about when we are talking about oligometastases or oligometastatic disease. It was about 26 years ago, I guess, that two guys in Chicago, Sam Hellman and Ralph Uxelbaum, coined the term oligometastases. And what they were trying to describe was a situation in which you are somewhere in between the very earliest stage of a cancer, stage 1 cancer, it's just limited, right, in one spot, all good, and somewhere beyond that, where the tumor is all over the place, widespread. It was a bit of a reaction to some of the two prevailing cancer theories at the time, if you will, the Halstead theory and the Fisher theory, never mind. But it was also called a spectrum theory because, again, they were trying to represent a spectrum of situations that you might encounter. And once again, I have a visual, which I think might just show it better than words I would spew out to you. So this is what I'm talking about. So historically, there would have been this dichotomy. You either have no metastases and you're totally curable because you had some tiny cancer and it's gone, it's not in your body, or it's everywhere, it's very widespread, incurable, too late and can't do anything about it. What they're proposing is that there are places in between those two situations and hypothesizing that for at least some cancers, there might be this situation of so-called oligometastases, just a few. You're on the pathway to getting widespread, but you're not there. And maybe there's an opportunity to use one or another form of local therapy, in this case, typically surgery or radiation treatment, to try to eradicate the few spots of disease and render a person free of those spots so that maybe they go back to being where they were to start with, right? In a good place with an outcome and outlook that would be as good as someone who was not diagnosed with any metastatic disease at the time of diagnosis. So that's the conceptual idea. The way that has played out since then has been 5 published studies and at least 10 more ongoing, which have addressed this exact situation. So the idea that in certain cancers, if you have a limited number of individually recognized metastatic deposits, and that number can be a little bit debatable, but let's just say it's a limited number, might you help the patient if you were to try to eradicate them with radiation therapy, intensive radiation therapy to one spot or those spots, or perhaps surgery or another ablative modality? There have been 5 studies in the past several years that have been published using radiation therapy in this context, ablative attempt radiation therapy. The 4 above the line have all been positive, let's just say. Of course, they were all small randomized phase 2, and the studies ongoing right now or larger phase 3 studies. There's one, however, that was not so good for small cell lung cancer. It was too much. Sometimes we give patients too much treatment, and I think that's how it played out for there. So the effort to try to eradicate so-called oligometastatic disease was not so successful in small cell lung cancer, but is very promising in the others, in particular lung cancer. It seems to be the strongest, and so that's encouraging. And so that remains a major area of focus for countless numbers of studies still going on right now. All right, I promised you that I was going to mention something that might be voted off the island to some extent, or at least is not still proving to be of such a high level interest because it's really been, let's just say, disappointing. And it goes something like this. There was, for quite some time, an interest in trying to combine radiation with so-called molecular targeted agents. The ones you're familiar with, I'm sure, would be the ones that are, say, tyrosine kinase inhibitors of EGFR and other tyrosine kinase small molecule inhibitors of specific cell signaling pathways. And that's something that a lot of people were spending a lot of time with because it was thought that those agents might, in general, be a little bit less toxic than chemotherapy. And if you're going to try to give it a 1-2 punch of radiation and another agent, that might be a better thing. This particular paper has a nice little sketch, and I'll just describe what they're illustrating in that particular sketch. They're trying to illustrate how radiation might interact with drugs or other systemic agents in any number of different ways. It might be that the drugs go over most of the body, but the radiation has to go where the drugs don't go, so I might need to get at the brain. Most traditional chemotherapies don't go there. You might have an advantage by having the chemotherapy around all the time and have some sort of circadian advantages with that, just have it all along. This biological cooperation is what these guys were getting at with the molecular targeted idea, and that is that you're interacting with cell signaling in a couple different ways. Traditional ways of enhancing radiation is that radiation and chemotherapy are both going after DNA generally, and so that you hit it with radiation, the DNA is all screwed up and then it's trying to repair itself, and then, oh, by the way, you have some 5FU sticking around, and when the DNA tries to repair itself, it inserts this other stuff that's going to totally screw up the structure, and that's how that works. And then, of course, there's some ways that we can try to give agents in the other direction, a few agents that are maybe going to be protective. But so that's just meant to represent the conceptual reasons why we sometimes do give radiation and a systemic agent. But the reason they were particularly still interested in this topic of trying to do something that was specifically going to target an intracellular signaling pathway is this one study that was high profile, came out in the New England Journal about 2010, and it was a study comparing radiation therapy with cetuximab, an EGFR inhibitor, versus radiation therapy alone for certain advanced head and neck cancer patients. And okay, that's a good thing. It was a 5-year survival data showing an overall survival improvement. That's a good thing. criticism there was that even by that time, there was already evidence that combining radiation and regular chemotherapy is better than radiation by itself. And so you could argue that what they had done there was a kind of a, well, I'm going to assume nobody here works for a pharmaceutical company. And if I put a mild put down and say that, gee, is maybe not surprising that sometimes pharmaceutical companies design trials that stack the deck perhaps in their favor. And so you could argue that the deck was stacked a little bit in favor of this drug because it might have a mild effect, but maybe not as strong as a chemotherapy would have. And as a matter of fact, maybe the side effects are not so benign. So be that as it may, there were eventually a couple of different studies. The one in particular I'm showing you here was the major US study that in fact compared radiation and cetuximab against radiation and, oh, guess what? Old-fashioned cisplatin, right? Been around a long time. And by the way, cisplatin did better and the side effects were about the same. And really with this particular study and a couple of other really uninspiring other stories, I think the notion, the concept that you're able to get away with something clever, something more clever than chemotherapy if you're trying to sensitize radiation is not flying these days. And so that's not really still a major focus, if you will. Targeted agents of the molecular targeted type are not, they don't carry the same cachet. The bloom is off the rose. Okay, I mentioned that we might also want to consider if we were going to do this time capsule again in 2021, what would we be interested, excited about adding to the time capsule? And there are two things I think that come to mind immediately. And that would be adjuvant immunotherapy and ablative radiotherapy for cardiac arrhythmia. So let's just see what that looks like. Probably the most high-profile study of the last 5 years in radiation oncology is the so-called Pacific study. It was a study of combination chemotherapy and radiation with or without immunotherapy, in this case, durvalumab, in non-small cell lung cancer. And lo and behold, significant overall survival benefit. Home run, absolutely. New standard of care overnight, all good. No question about it. This is a great use of immunotherapy, as it has, of course, entered into a very important role in combination with chemotherapy in a number of different cancers. But there it is. There's a nice combination. And so, there's been numerous other studies looking to see, well, can that sort of thing happen in other cancers? The jury's still out on that. There was a recent, somewhat disappointing study in head and neck cancer. It didn't seem, immunotherapy of this sort did not seem to have the same advantage in that setting. And for some other cancers, I would say the studies are still ongoing. But be that as it may, this is a home run. This is a big advantage, legitimate benefit. One of the first things to move the needle for stage 3 non-small cell lung cancer in quite some time. So something to be celebrated and something to continue to develop as much as possible. That other thing I mentioned is sort of out of left field. Non-invasive cardiac radiation for ablation of ventricular tachycardia. This is outside the cancer space, right? This is not an oncologic situation. But here's what's going on. There are patients for whom medications that are employed to control certain types of cardiac arrhythmias are simply not completely successful. And the patients wind up getting, implanted devices to try to shock the heart back into a regular rhythm and monitor things and all that. It's actually not a pleasant experience for patients. So other modalities that are used to try to get rid of these places in the heart septum and heart muscle that are starting the arrhythmia are often not able to penetrate deeply. So there's a couple of other tissue ablative techniques that are used, but sometimes the tissue is too thick. So lo and behold, it came around that some groups started to think about, well, what about using radiation to try to do this? And so the leaders in this field, the group from WashU and St. Louis, the paper that set everybody in a fever and a frenzy about this came out in 2017. And it was a pilot study that's since been continued, but I just show you what's going on with it right now. So, right there. So there are some sophisticated ways to image where an arrhythmia is starting in a heart. There are certainly some ways that we can direct radiation if that's what we want to treat. We're usually trying to avoid the heart, but in this case, sure, let's treat it. Let's go after it, because if that's what we're actually trying to hit, we can hit it if we want to. What you're seeing on the right is for the first pilot cohort of patients, some outcome metrics. And in this particular case, the upper, upper graph is number of arrhythmias happening up to and then after the treatment, and below is probably the more important one, how many shocks these patients got in the 3 months leading up to it and then afterwards. Because never mind if you just have an arrhythmia that, okay, you have something that it comes and goes. When a person actually gets one of those defibrillating shocks, it is not a pleasant experience. I've seen videos of it. I've never seen it in person, and I've heard, and patients have described it to us, and it's not a fun thing. So avoiding the need for those things to go off is a useful thing for a patient's quality of life. We have done a single index case here. Wendy Zoe is the electrophysiologist I've worked with. She's terrific. We're trying to walk it out very slowly, very carefully, and not do anything rash. At the moment, it's on a sort of compassionate use setting. Knock on wood, the one person that we treated so far is doing okay 6+ months later. So I hope he continues to do okay, and fingers crossed on that. Okay. So I mentioned I was going to come around to the end and just touch on a couple of quality and safety things that we have going on here. I was going to call this an intermission because I was going to go straight into yet another movie. I thought about having the whole thing just be like movie after movie, but I figured, well, that's a little bit too lazy for me. However, you do have one more movie coming up to you if you can stand it. And I'll tell you what that movie is going to be. That movie is going to be showing you something that we call Radflix. And Radflix, what the heck is that? It is a distraction technique that we've implemented in the last few years. So imagine a pediatric patient getting cancer treatment. Imagine, you know how scared an adult is, and just multiply that by some large number. You can imagine how scared a youngster is. In this case, one of our acute patients, I think she's about 8 years old, this gal. She agreed to be interviewed and filmed for some of the media presentations. This is from local publication 2 days ago. We've had some local news on this, and it's a nice little thing. So what's going on here is that we are going to have the patient see a movie while they're getting a treatment. We're trying to just distract them, let them see a Disney movie or something like that. The key people who worked on this are Doug Holt, one of our residents, Brian Miller, one of our med physicists. He's key, I'll tell you why in a second. And Sarah Milgram does most of our pediatric radiation treatment, and she's been leading this initiative. This guy's role, we're lucky to have him on board, is that in part of his background, he has optical engineering in his background. And the trick of this, the actual intellectual property of this, if you will, is a special lens that can throw the image onto the back of a screen. And so what I'm gonna do is, hey, I told you got one more movie in you. This one even has sound. So we're gonna, it's sped up. That's not a real patient, that's one of our residents. And she's got a mask that's looked like one of the popular cartoon characters nowadays. So you can see that she's watching a movie, and hold on to your hats now because it's not that a GoPro on the machine, so a little different view of what's going on. This is the machine moving around, the patient is lying down still. The patient's not upside down, I promise you. The machine that's upside down. It's going to move around a little bit, and you can see a little bit. But the whole time, once you're ready, whatever that is. And that's how really like it's not just for the purpose of help have patients relax or that's for you. Also, there are a couple of people that are on the fringe of needing anesthesia or not. I mean, below a certain age, a youngster is just not going to be able to stay still by themselves. And but there's a borderline of sort of ages 4 to 7 or so, where if you can only get them to be a little bit more relaxed, they might not have to get anesthesia every day to keep them asleep during the treatment. And so we think we're able to use this and catch and be able to avoid having the potentially disadvantageous, the disadvantageous features of general anesthesia on a daily basis for, let's say, 30 or so treatments. Okay, the one last topic I'm gonna show you are some slides from a presentation that's been making the rounds. And so it's possible you've even seen this at another meeting or so, but I'm very happy that it's gotten a little bit of traction around here. It's just a report of some of our quality and safety committee activities over the last 7 or 8 years, spearheaded by Sam Nath and Leah Schubert, who sort of co-direct this particular initiative. And so the whole idea here is that if you have this multi-step process with a lot of moving parts, you really don't want to have any accidents, right? And it's really best if you can, if at all possible, identify the things that are maybe either unsafe conditions or an unsafe act, meaning something bad could happen, this might not end well. You certainly would rather do that than have a near miss where it's like, wow, something bad did happen, we just got lucky. And of course, there's an accident. So some time ago, we initiated a process where we wanted to emphasize to the entire group that we're going to try to get a culture of safety going here, non-punitive environment, have a mechanism through which individuals who work in the department could report unsafe conditions or unsafe actions, hopefully before near misses, and we would have continuous reviews about these things and efforts to improve the process. This has now evolved into about a 20-person committee with representatives from all the different stakeholder groups within our department, twice monthly meetings. We've added some residents here. And over the past number of years, last couple of years at least, we collected 600 individually volunteered reports. The denominator, if you will, is 50,000 treatments or so, and maybe another few thousand individual clinic visits, but it's mostly the treatments that we're worried about. You can see that the folks who report them are mostly the therapists, the people who are at the machine, and the other technical people who are doing it. We get a few from the MDs here and there, and some from the nurses, of course. Fortunately, very few have actually been to the patient level, and we think that it's this. We hope that by having created this culture of safety and this willingness to report and this willingness to analyze in a non-judgmental way, that we think that it's helpful to us, that we've managed to avoid serious things going on, knock on wood. This particular group has also worked on some recent large-scale initiatives to put in some new policies and procedures, anticipating ways to improve some of the trickier businesses that we get. People with pacemakers, patients with pacemakers, we have to monitor them in special ways. So we have some guidelines on that. Nursing education needs to be done a certain way, and a few other operational efficiencies we're trying to get smoothed out. There's been some academic productivity from this. There's some publications that have resulted from some of these efforts. And last but not least, we actually entered into an international competition from the International Atomic Energy Agency. The entry was actually a film. I'm not going to show you another film. You've already been subjected to 3 individual movies, but we actually submitted a movie that featured our folks in our department and highlighted that we do a safety month. And in fact, we're judged in the top 3 of the 150 applicants. And so that particular video is now part of the IAEA's International Radiation Safety materials. And so there it is. Oh yeah, by the way, what about Einstein? I told you I'd say about Einstein. So actually, after 1938, the same time capsule people went back in 1965 and put some more stuff in there. But what the heck? Let's just see. What did Einstein say? He says, "Our time is rich in inventive minds. We have learned to fly and able to send messages and news without any difficulty. However, distribution of commodities is entirely unorganized, so that everyone must live in fear of being eliminated from the economic cycle. Furthermore, people living in different countries kill each other at irregular time intervals, so that anyone who thinks about this future must live in fear and terror." Now he's writing this, there's Nazi Germany going on at the time, and he just says a few suggestions about that. And he's just like, I certainly trust, I hope that posterity will read these statements with a feeling of proud and justified superiority, meaning I sure hope people in the future have figured out these things, because we're struggling with them right now. So that's sort of what he said. Okay, I'll stop right there. Thank you so much for your attention. If there's any time left, I'm more than happy to take questions.
Thank you, Dr. Kavanagh. That was great. We do have one question from Marie. She asked, is Gamma Knife used for glioblastoma or just other types of brain tumors?
That's a great question. It has been, so this idea of trying to just focus on a spot within the tumor has been tried. It doesn't prove to be advantageous to only go to a pinpoint area for glioblastomas. We wind up having to treat a larger volume over a 6-week period. And so the standard is to use the other type of machinery for GBMs.
Great. Are there any other questions? There was one from Sherry asking if adults could have the rad flicks as well as children.
Yes, we do have that offer on the table for anyone. And it's true, some people, I mean, of course, sometimes those are the people we just say, well, if you're nervous, you know, we could just give you a little Ativan or something like that. That would be okay too. Yes, they could have Ativan or try Radflix, sure.
All right. Well, thank you so much for joining. Thank you, Dr. Kavanagh, for your presentation.
My pleasure. And, you know, if you think of something afterwards, you know where to find me. Email me. I'm here.
Thanks so much. I hope everyone has a great day.
Thank you.